Good evening all. The presentation topic for today is systemic association of congenital ectropin UVE. So it could be congenital and acquired both. So acquired is the condition where there's other secondary involvement where the patient develops NPI which leads to fibrosis, and then the patient develops ectropin UVE where there is ectropin of the posterior pigmented iris epithelium. So CEU patients have glassy smooth iris with anterior iris root insertion and TM dysgenesis. Mostly they have open angle glaucoma, but later it converts into angle closure also. Associated syndromes already been in the literature is neurofibromatosis, Prader-Willi facial hemihypertrophy, and Riga anomaly. This is a neurocristopathy because it is attributed to the arrested development of NCC. And another document why it is neurocristopathy is that Muller muscle is also involved. Such patients present with mild ptosis also. So we have two cases. Case first was of a 15-year-old male who had diminution of vision and headache from the past 1 year. He was already diagnosed with glaucoma in the left eye and on topical AGM. At presentation, visual acuity was 6.9 and IOP was 28. And on Hertels, the values were 21 and 23 at base 110. We can see a left-sided facial scar which showed cleft lip surgery in the past, left-sided ptosis with mild proptosis. The anterior segment photos showed a crippless iris with ectropin UVE at 360 degrees. Fundus photo showed a vertical coverage ratio of 0.8 with this pallor and inferior NRR thinning. So the patient had fluctuating IOP with even on AGM. So he was planned for trabeculectomy and is doing well and has achieved target IOP in the 6th month of follow-up. Second case is that of a right eye female of 27-year-old who had a right eye diminution of vision. Vision was PL positive and patient had RDS with her right-sided facial hemihypertrophy, mild ptosis and proptosis also. GAT was 38. Anterior segment photo showed a 360 degree of ectropin UVE pupillary frill of 3 to 4 mm, which was abruptly terminating at temporal pupillary margin. And the gonioscopy showed a high iris insertion. The coverage ratio in the right eye was 0.9 with NRR thinning, and with the left eye fundus was normal. Patient was advised trap, but since she came for cosmesis for the squint surgery, she denied for trabeculectomy surgery. So CU is a rare ocular disorder with trabecular dysgenesis along with anterior placement of posterior pigmented iris epithelium. These conditions could be confused with other trabecular dysgenesis like Axenfeld Rieger. Till date, only 100 cases have been reported in the literature, and these are all associated with Prader-Willi or neurofibromatosis, but none have showed other systemic association like in our case series. So such patients have high risk for glaucoma and in early childhood, and they present even around teenage group. So these are non-progressive to begin with, but later on as the glaucoma becomes angle closure, they become progressive. So there was stark difference in the age of presentation, that is it was around a decade. And so this shows how early presentation saves the vision, and TRAB is also necessary. Though a rare syndrome, its association with systemic disease and progressive glaucoma in children can culminate in potential blindness, and angle surgery, although it's a mainstay for childhood glaucoma, does not yield good control in CEU. And irreversible nature of the disease makes it to be more important to be evaluated periodically. Thank you.
Can you please repeat the gonioscopic findings of the two patients?
In the first patient, the gonioscopy was in post-trabeculectomy surgery, where we can see the patent PI, and there was anterior root insertion of the iris. And the second angle, in the second patient also we had the same findings. And one thing which I forgot is that the second patient had adenocarcinoma of the colon, for which she was operated 5 to 6 years back. That was the syndromic finding in the second patient.
Yeah, I was wondering what was the systemic association in this case. So adenocarcinoma of the colon. Is there a genetic or a polymorphism which has been implicated in this? Does the literature say something?
Some genetic polymorphism has been suspected, but not for carcinoma colon. Like something like this has not been reported.
It has not been reported previously. And the systemic association in the first case?
This has also not been reported. Only associations have been with neurofibromatosis and Prader-Willi and facial hemihypertrophy, which was present in both the patients.
That was there?
That was there in both the patients.
In both the patients, okay.